Okay, everybody, thank you very much for attending the tutorial this morning. I know that it is a very early start for those of you who are scheduled for the first prac session that starts at 10 o'clock, so I do appreciate you attending. So this tutorial is another pre-lab this week, so it is explaining about the antiglobulin test and how we are going to be using it, particularly the indirect antiglobulin test, how we use it in antibody screening. Okay, so the main things that you really need to be able to do, you need to be able to compare and contrast the indirect antiglobulin test and the direct antiglobulin test. You need to be able to compare and contrast the methods of these two tests, what's the same and what's different, the clinical and laboratory applications of these tests. So when, in what sorts of clinical situations we would consider using an indirect antiglobulin test or a direct antiglobulin test, and the application within the laboratory. So when we use it in the laboratory, what we use it for. You do need to be able to explain that term screening cells, and you need to be able to describe them in the way that the ANZ SBT guidelines describe them, and we'll come to that when we have a look at them, when we get to that learning objective. And we touch briefly on serological methods that we can use to when we are not so much when we're detecting antibodies, but when we're trying to identify them. There are a number of different methods that I'll introduce you to today that we will look at more closely in the weeks to come. Okay, so first of all, what I'd like you to do is to describe this image to me, starting off. So this is just some recalling from our lecture the other day. So our sensitized red cells here. So starting off from this image, I would like you to describe what you see on that slide. So you can just describe this to yourself, or you can write it down, or if you're sitting with somebody else, you can describe it to each other. So I'll give you a couple of minutes to do this. Okay, so I've just given you just under 2 minutes. So it's really, really important that you are able to put into words an image such as this, and that you are able to draw a diagram like this. Okay, so it's something that maybe in an exam, you know, you may be asked to draw a diagram of the principle of the AGT, or you may be asked to describe an image, or you may be asked to describe the principle. So you should have said something like sensitized or red cells on their own, or IgG antibodies on their own, are not able to cause a direct agglutination of red cells. because of it's not able to bridge the gap between them, which is caused by the zeta potential. So again, there's that term zeta potential that we'll look at in a minute too. And so because all of the IgG can do is to sensitize the red cells, the principle of the antiglobulin test is that we add an agent that has an antibody in it that is able to cross-link these sensitized red cells. So we react the sensitized red cells with an anti-human globulin. So that's antibody to the IgG antibody, to the Fc fraction of it. And that is able to bind the antibody and the red cells and bridge the gap between them, cross-linking the red cells. And the result is in vitro agglutination that we can visualize. Okay, so that's what we're aiming for, is being able to visualize whether or not there is an antibody put on those red cells. So that is the principle of the antiglobulin test. So that is the general test, and then we have two specific tests that use that principle. One is the indirect antiglobulin test, and the other one is the direct antiglobulin test. But that is the principle of both of those tests. And so remember that the zeta potential is the difference in charge density between the inner and outer layers of the ionic cloud that surrounds red cells in an electrolyte solution. And it is that ionic cloud, or the zeta potential, that prevents the red cells from clumping together in our blood vessels and allows them to move smoothly through our blood vessels. IgG antibodies are too small, as you can see here. They're only 14 nanometers across from their two arms, their FAB arms, and they're too small to bridge that gap, whereas IgM antibodies, because they are a pentamer, they are able to bridge that gap. Okay, so the anti-human globulin, which is the Coombs reagent, comes in, and because it is an antibody, it is able to bind to the Fc portion of the IgG antibodies and bridge this gap, and therefore cross-linking the red cells, causing agglutination that we can visualize. When we are comparing and contrasting our indirect antiglobulin test and our direct antiglobulin test, remember, compare and contrast means what's the same and what's different. So the first thing that's the same is the fact, the first thing that's different we'll go to. The indirect antiglobulin test is checking for IgG antibody in the patient plasma, whereas the direct antiglobulin test is checking the patient red cells and to see if they have already been sensitized with IgG antibodies. So the direct antiglobulin test tests the patient's red cells. The indirect antiglobulin test tests the patient's plasma. Okay, so they are the two main differences. And then the other difference is the fact that in the indirect antiglobulin test, we have this sensitization phase. So that's the other difference between them. Because in the direct antiglobulin test, the red cells have already been sensitized. Okay, they've already been sensitized in the patient, so that's in vivo. The indirect antiglobulin test, we are actually sensitizing. We are, if there is an antibody in the plasma, then we are trying to sensitize reagent red cells with that antibody. Does that make sense? So we use, in the IAT, we use red cells that we know the antigen mix of on them, and if there is an antibody there, it will latch on to those red cells. So that's what we call our sensitization phase. In the direct antiglobulin test, that has already happened in the patient. And then the rest of it is the same. So we have our sensitized cells, we wash away any patient plasma that remains that may have unattached antibody in it. So we do that for both cases, for the indirect and the direct. And then we add AHG, our anti-human globulin, to both. And then we mix it, centrifuge it, and read and look for agglutination. Okay, so the red is what is different and the black is the same. Yep. Whoops, where are we? So we normally use the indirect method for a couple of things. So we can use it when we are checking for IgG antibody in the patient plasma. So we can see if we're going to be detecting an antibody, if there's an antibody there. And then we also use the IAT when we actually identify the antibody. So they're the main times that we use the indirect antiglobulin test. Okay. Just going to make that a bit smaller for me. There we go. That's just make any difference. Okay. Okay, so that is what's the same. What is the same is what's in those boxes. And then for those of you who like a picture, because really who doesn't like a picture, at the top there we have our direct antiglobulin test where we are testing the patient cells that have already been sensitized within the patient. Okay, whereas the indirect antiglobulin test, we are testing the patient plasma, and we are, if there is an antibody in the patient's plasma, then we are sensitizing our reagent red cells with that antibody, and then add our Coombs reagent in each case, and then we can get a positive or negative test result. I really like those images, they're really nice. So hopefully that might help you with your understanding of the two tests and the differences between them. So when we're looking at the different tests, and again, what is different between them, part of that sensitization phase of the indirect antiglobulin test, we need to allow time for any antibody present to attach to our reagent red cells. Okay, in the direct antiglobulin test, that has already happened, so we don't need to allow any time for that. So the direct antiglobulin test is really, really quick and quite easy to do. Whereas the indirect antiglobulin test, we have this incubation time. We incubate at 37 degrees. And why do we incubate at 37 degrees? Why don't we incubate at room temperature? Beautiful. Yes, it's optimal for IgG antibodies. And that is also body temperature as well. And so our clinically significant antibodies react at 37 degrees. So it's that incubation phase again, which is different. And as you can see, that's part of the sensitization phase. So initially, when the indirect antiglobulin test was first devised, that incubation phase was 1 hour. And because we don't, we're busy people, we can't wait 1 hour, then they found that by adding albumin to it, so cells plus plasma plus albumin, brought it down to 30 minutes. But using what we call potentiators or enhancement media, we can actually reduce that to 10 minutes. And the enhancement media that are used are what we call low ionic saline solutions. And so that's what LIS stands for, low ionic saline solution, or BLIS or RAM. I can't remember, that could be the brand name there, the B, and RAM is rapid action medium. So they're just different names that the different companies have used for the same thing. So these things, they have lower ionic strength, and so by reducing the ionic strength of the solution, you are reducing the electronegativity of the inner and outer layers of the zeta of that ionic cloud around the red cells. So that's how it reduces the zeta potential. It actually reduces if you like, the size of that cloud or the electronegativity or the electrical potential of that cloud. And so that enables the cells to come closer together. And also, it also exposes ionizing groups on the antigen and the antibody. Because saline partially neutralizes these groups, and so the enhancement media helps to increase the attraction, if you like, between the antibody and the antigen. So it increases the avidity of the antigen-antibody reaction, and so instead of having a weak reaction, it can increase the strength of the reaction. And it also, and therefore, as I said, increases the attraction. So it reduces the zeta potential and it increases the sensitivity of the test. It does increase the risk of false positives to a degree, Jordan, which is why when you are incubating using these enhancement media, it's really important to not go past 10 minutes. Okay, that's when you're likely to get a false positive if you incubate for too long. And so you incubate for 10 minutes at 37 degrees. That is the optimum time when you're using what we call enhancement media or potentiators. Okay, and so that reduces the time of incubation down from its original 60 minutes down to 10 minutes. And so that's really great. Makes it a lot faster. Okay, so what I'd like you to do now is to think about the applications of the indirect antiglobulin test and the direct antiglobulin test. See if you can recall those applications from the lecture and from today without actually checking your notes. Yes, Z, because we are impatient people, and because we you know, in emergency situations, we want to get that, make sure that we have got compatible blood for our patient, that we're not going to upset or cause them any harm. Okay, so we talked a bit before about the applications of the indirect antiglobulin test. Can you remember what we said? The indirect one. What did we say? Who was it who asked me the question before? Let me see. I think was it Poppy? No, it was Yushin. Yushin, can you remember what we said about when we normally use the indirect method? Yep, to test antibodies. And where are we looking for the antibodies? Whose plasma? Lovely, well done. Okay, so we use the indirect method when we are checking a patient's plasma for the presence of unexpected antibodies. What does that term unexpected antibodies mean? What's the difference between expected and unexpected antibodies? Not so much that they're weak. When do we expect to see an antibody? Beautiful. So unexpected antibodies are immune antibodies, so they're not naturally occurring antibodies. Okay. So back to my other question, when would we expect to see antibodies in a patient's plasma? And I think this is a question that I asked last week as well. Right, okay, but not all RHD positive with an anti-D? Might have to think about that one a little bit more carefully, Renee. Yep, so our naturally occurring antibodies, and when do we see naturally occurring antibodies, Z? ABO blood group, yes, that's right. So when we're doing our ABO blood group, we expect to see our antibodies in our patient's plasma to the antigens that our red cells lack. Okay, so our unexpected antibodies are immune antibodies, have been produced through prior sensitization. So can anybody think how we might be sensitized to red cell antigens that we don't possess? They can certainly modify our ABO antigen. So exposure to the antigen itself. So when would that happen, Z? Not so much vaccination, Kiani. It's a similar, it's very much an immune response with vaccination, but with our transfusion science, it's to do with a transfusion. So if somebody has had a previous transfusion, and what's the other time when we can get prior exposure to antibodies? Happens in women. Yes, pregnancy. So on your request forms, you will always see that there's a spot there that lists any prior transfusions the person has had and how many, and any pregnancies, not how many babies have been born, but any pregnancies. Okay, so somebody who is pregnant and unfortunately experiences a miscarriage can, if there can be still a transplacental bleed there, and so they can still be exposed. So that's why you see prior transfusions and pregnancies. Okay, and in the cases where they have prior transfusions and pregnancies, then you keep that in mind when you are screening them, because you may very well find an immune antibody that is normally meant to be there. Okay, does that make sense to everybody? Okay, so the direct antiglobulin test, when do we use that? When did we use it in Heme 2? When did we consider it? Testing for conditions of extravascular hemolysis? Yep. So would you expect to have a positive direct antiglobulin test for hereditary spherocytosis, Amelia? No, you wouldn't. Okay, but it's when we see spherocytes, isn't it? Anytime we see spherocytes in a blood film, the first thing that you could do is to ask for a direct antiglobulin test, because it takes about 2 minutes. So the direct antiglobulin test, when we see spherocytes, what information does that give us about our extravascular hemolysis? Well done, Sarah. Immune or non-immune? Okay, so which one would give us the positive direct antiglobulin test? It's 50-50, come on. Yay, well done, Bassem. Yes, the immune one would give us the positive direct antiglobulin test, because immune means antibodies, and the direct antiglobulin test is detecting or seeing if there are any antibodies present, isn't it? Okay, so in immune hemolytic anemias, immune causes of hemolytic anemia, you would expect to see a positive direct antiglobulin test. Okay. So there we go. So we've got screening for IgG blood group antibodies in the plasma of patients. And so we do these screens in a preoperative situation. So before a person's going to theatre, just to make sure that if they do have an antibody there, we have got time to identify the antibody and find group compatible blood for that patient. We also do it for women, pregnant women. So anybody who in Australia, women who become pregnant usually go and visit their GP and are tested in their 12th week of pregnancy for a number of things, including their ABO blood group, the ABO and RHD blood group, and their plasma is screened for antibodies, just in case we need to monitor them throughout their pregnancy. And also, when we're doing compatibility testing, we mix donor red blood cells with the patient plasma and perform an indirect antiglobulin test there as well. Also, as I said, when we are identifying antibodies, and also the other thing that we use it for is when we're doing some blood group phenotyping. So depending on the reagents that you're using to do your phenotyping, you may need to use an indirect antiglobulin there as well. If your reagent contains IgG antibody to the antigen that you're trying to identify on the patient's cells, then you will need to do an indirect antiglobulin test. The direct antiglobulin test, of course, here, this is what we talked about here, autoimmune hemolytic anemias and also hemolytic disease of the fetus newborn. The other time when you will get a direct antiglobulin test is if you have a post-transfusion transfusion reaction, usually a delayed transfusion reaction due to an IgG antibody. So you will get a direct antiglobulin test then as well. Okay, so any questions about that first objective before we move on? Because I recognise that we're probably running short of time a bit. If you haven't got any questions that come to mind now and you have questions later, then of course you can pop them up on the week 3 discussion board. So now we're going to go and have a look at the screening cells and the panel cells. So we talked a little bit about these last week, and I think I explained to you that basically they are reagent red cells that have been tested for antigens to the clinically significant blood group antibodies, because not all blood groups are clinically significant, only those that have antibodies that react at 37 degrees. And so you can see here, so this information is from the ANZ SBT guidelines. And so the screening cells that we are mandated to use are cells with a known antigenic profile. And so we know the antigens that are on them, and you can see there is an example of the sorts of antigens that the screening cells will possess. They must be group O. Why must they be group O? Why can't we use group A cells as screening cells? Absolutely, because we don't want, I don't need to spend too much time on this slide, obviously. Yeah, because we don't want our ABO blood group antibodies getting in the way of us trying to see if there are any other clinically significant IgG antibodies in the plasma. So we use group O because the ABO antigens are not on those red cells. Okay. You can see here that it's very important that the antigenic profile reflects the population that you're testing. And so the screening cells that you would use in some parts of Australia would be different to screening cells that you use in other parts. For example, you might use a different set of screening cells in Western Sydney, where the ethnic mix of the population is a little bit different than it is in Launceston. So there are 2 or 3 different variations of screening cells that you can use, but the ones that we use have these antigens on them. So the antigens are expressed in different combinations, and this is my favourite part of transfusion science, is when you get an antibody there and you get a pattern of reactions that you then have to try and tease out and to try and identify. And that pattern of reactions is further complicated by the fact that some antibodies will work stronger when they are mixed with cells that are homozygous for the complementary antigen, and they will react weaker with cells that are heterozygous for the complementary antigen. So what do I mean by homozygous and heterozygous? What's the difference between those two terms when you've got red cells that are expressing homozygous expression of an antigen or heterozygous? What does that mean? Big capital. I think. So what do you mean by dominant recessive, Kiani? Yeah, not quite so much Mendelian inheritance. So yes, I guess, Poppy, what you've written there is an example of homozygous and heterozygous. So most of our blood group antibodies are actually co-dominant in their expression. If the antigen is there, sorry, the blood group antigens, if the antigen is there, then it will be expressed. Yep, so that's right, Sophia. So you could, I would have, I don't know why you're using H's. What about, look at the, okay, with our RH antigens. So remember our RH antigens, we've got D or absence of D, we've got big C, we've got little c, we've got big E, we've got little e, haven't we? So people can express just big C, can't they? So they can inherit a big C from either parent, or they might inherit a big C from one parent and a little c from the other parent. Or and we can have big E and little e, so they might inherit two big E's, one from each parent, or two little e's, one from each parent, or a big E and a little e, one from each parent. Yeah? If you've got two of the same antigen, then you're homozygous. If you've got big C, then you're homozygous big C. If you're heterozygous for C, then you will show expression of big C and little c. Okay, does that make sense? If you're homozygous for the little e, then you'll only express little e. If you're heterozygous for the E antigen, then you will express big E and little e antigen. Yep, great. So that's homozygous and heterozygous. So with some of our blood groups, the antibodies are very fussy about how they will react with the antigens, and they react much more strongly with their homozygous antigen than they do with the heterozygous antigens. And so we use these screening cells and the panel cells to help us to detect the unexpected antibodies in the patient plasma. So this is what we use when we are using the indirect antiglobulin test. And these are the cells that we are trying to sensitize if there is an unexpected antibody in the patient's plasma. And so that's what this group and screen or group and hold means, is that we're doing the ABO and RHD group on the patient, and we are checking their plasma to see if there are any atypical or unexpected antibodies in the plasma. Okay. So when we have a look at our screening cells, the cells that we use are the ABTEC cells, and they are a set of 3 cells, and I showed these to you last week, I think 2. So you can see that ABTEC cell 1, ABTEC cell 2, ABTEC cell 3. So ABTEC cell 1 or 2 are the cells that you use when you're doing your daily QC to check that the anti-D antisera is working, and ABTEC cell 3 basically gives you a negative result, because when we have a look down here, we can see that screening cell 1 and screening cell 2, ABTEC cell 1 and 2, are positive for the D antigen, so the D antigen is on the cells. ABTEC cell 3 is negative for the D antigen. Okay, so there's a 0 there. And you can see wherever there is a plus on this in a column here, then that means that the antigen of that blood group system is present on the blood, on that particular cell. So ABTEC cell 1 has these antigens present, ABTEC cell 2 has a slightly different antigens present, and ABTEC cell 3 is different again. Okay, so they help us to give a slight, first of all, they help us to identify, detect whether or not we've got an atypical or unexpected antibody there, and also that initial pattern of reactions between those 3 cells can actually guide us as to what that antibody might be. So the difference between the screening cells and the panel cells is the number of cells that are there. Okay, so the screening cells, they screen our plasma to see if there is an atypical or unexpected antibody present, and the FINA cells, what we call the panel cells, are what we use to identify the antibody. So you can see here, antibody identification panel. Okay, and if we do use one of the a panel, a set of panel cells to identify an antibody, you need to write the patient's details up here, and also your detail, you know, that your initials or your name there and the date that you tested it. Okay, and again you can see that instead of 3 cells we've got 11. And again, the same deal, the pluses indicate which antigen, blood group antigens are present on the red cells, and the zeros indicate where that antigen is absent from the red cell. And again, so what you do is you react your patient's plasma with each of these panel cells, you get a set of reactions that you write down here, and then you see if your set of reactions matches any of these sets of reactions to see if you can identify the antibody you have, and then you go through a process of what we call crossing off, which Melina will introduce you to in your prac sessions this week, and we will talk a lot more about in the weeks to come. Okay, so that's the panel cells and the screening cells, but they both have to follow the same rules, and that's the ANZ SBT guidelines, and I think they are on page 21 of your method manual. So have a look at those guidelines. They're really, really important. So just to finish off with, just a quick look at the screening methods that we use. So they're not so much screening methods, I guess they're more methods used when we are identifying antibodies, because a lot of these methods are no longer used in the lab as screening methods. So when I was in the lab, we used to do an immediate spin. So that's basically what you do when you're doing your ABO and RHD blood grouping. That's an immediate spin because you are adding known antisera to patient cells, you are adding patient's plasma to known reagent red cells, you're giving them a mix, you're putting them in your centrifuge, spinning them down, reading them. Okay, so it's all done at room temperature, nothing else is added, it's just patient cells or plasma and reagent cells or antisera. Okay, so and it's all done at room temperature, and that's called an immediate spin. So when I was in the lab, when we used to actually do that immediate spin before we went on and did the incubation, which is the second part that you see there. And then we used to also, after we had incubated our cells, so this is the IAT or the sensitization phase here, the 37-degree incubation. So remember, this is where we're adding the patient's plasma and the our reagent screening cells or panel cells, and we also add our enhancement media here so that we only have to incubate for 10 minutes at 37 rather than 60 minutes at 37. And then what we used to do was to spin and read directly after this to see if we could check for any IgM warm reacting IgMs, because these are the only ones that are clinically significant, the IgMs that react at 37 degrees. These days we don't bother doing either of these. We just do the IAT, because research has shown that if you do have a warm reacting IgM antibody there, it will still show up in the IAT. So there will still be enough of a reaction there to show up if we have an IgM, a clinically significant IgM antibody. And by just doing the IAT, we are reducing the likelihood of detecting a non-clinically significant IgM antibody that will just waste our time trying to identify. Okay, so that's why with our antibody screening methods, we only do the IAT, and we'll be having a look at that in a minute. Method. These enzyme techniques are quite useful, as you can see here, for antibody identification, because they, particularly when you've got a mixture of antibodies. So sometimes you can get 2 antibodies, sometimes you can get 3, sometimes you can get lots. When you get mixtures that you're unsure of, then or any mixtures actually, they usually get, the patient's sample usually gets sent away to a reference laboratory, and those people are the ones who usually do these extra techniques, the enzyme techniques. And so you can see here they're very good for antibody mixtures because they enhance some antigens and therefore make some antibody reactions stronger, and they will destroy some antigens. And so, you know, you can see the difference between when you've used enzymes and when you haven't, and you can work out what your antibody mixtures are there. But more of that in the weeks to come. I think in week 6 we actually look at how you resolve antibody mixtures. So that's just a taste. But yes, IAT is the only one that's used these days in a routine laboratory. Okay, so this is the screening method that you'll be using when you do your using your IAT to do your antibody screens. So you can see here that we add a patient plasma rather than serum. Patient plasma, 2 drops of patient's plasma, 1 drop of the screening cells, either ABTEC cell 1, 2, or 3. And then we use a positive control. Why do you think we use a positive control rather than a negative control, or both a positive and a negative control? The reason why we only need a positive control is because only about, I think it's only 2 to 5% of the population actually have an unexpected antibody in their plasma, but we still need to detect it if it's there, because it can lead to a poor outcome for the patient if they do have an antibody there. And so we do need to check for it, even though the likelihood of it being there is quite low. And so we are expecting negative reactions. That 90% of the time when you do this test, all of these reactions will be negative. So we need to include a positive control just to reassure ourselves that our test is capable of detecting an antibody in the plasma if it's there. Okay, so that's why we use a positive control. Why do you think we use a weak anti-D with our ABTEC cell 1 or 2 and not our usual nice, big, robust, strong anti-D that gives us 12 plus reactions? Well, I think we only use a weak one. Because we want to make sure and be happy. Yeah. Because we want to make sure that we can detect weak agglutination reactions, not just the strong ones. We need to detect the weak ones as well, because remember, we've got those pesky antibodies that prefer to react strongly with the homozygous antigens, and stronger than and they will only react weakly, and some of them won't react at all with heterozygous antigens. And so we need to make sure that we can check, pick up those weak reactions. So once we've added our patient's plasma and our reagent red cells, our screening cells or our panel cells, then we add our enhancement medium. So remember, this enhancement medium allows us to only incubate for 10 minutes because we're very busy in people, aren't we, Z? So after the incubation time, we need to wash our cells. So we wash the cells to remove the enhancement medium, to remove plasma and plasma proteins, and also to remove any unbound antibody, because that unbound antibody may be able to neutralize our Coombs reagent. AHG. So remember, this is our bridging reagent. So we want this reagent to react with the IgG that's bound to the red cells. We don't want it to react with any IgG that's free in the plasma. Okay, because it will. If you don't wash the cells properly, that's what will happen, and that will reduce the strength of your agglutination. So you need to make sure you wash the cells quite thoroughly. And then once to the button of cells in your final wash, you then add your AHG reagent. I think it's 2 drops of the AHG, but just check your method book for that. That will tell you. Then you mix well to make sure that the button and the AHG is mixed. So your red cell button with any antibody attached to the red cells is mixed well so that it can interact with the AHG. Then you centrifuge at the correct speed for the correct time. And then you read each tube, the agglutination reaction of each tube one at a time. You record it one at a time on your transfusion sheet. Then you check your reactions with your tutor, because any of you who have looked at the video about how to set up and perform a screening, an antibody screen, will know that we add 1 drop of what we call Coombs positive cells or Coombs control cells to each tube that has a negative reaction. Why do we do that? To ensure it's not a false negative. Well done, Kelly. Yep. Okay, to make sure that we have actually added our AHG reagent to all of our tubes and we haven't missed any out. Okay, and so then once they have been mixed, read, all of these tubes should be positive. Okay, but there's no point showing your tutor your antibody screen tubes once you've put the Coombs control cells in there, because they'll all be positive, won't they? So check with your tutor before you add your Coombs control cells to your negative reactions. Okay, so that is the a beautiful image from Harmoning from your book, and so again, that's for people who like images. So looking at the outline of the indirect antiglobulin test, where can we make errors, do you think? Yeah, not adding reagents in the sensitization phase. So what could we do in the sensitization phase? Water bath not at 37, not incubating for the correct time, going under or over, not adding patient's plasma, not washing the cells thoroughly enough, not adding the AHG, mixing the wrong cells, good one, yep. So there's lots of scope really for error with your IAT. So it is important that you follow the protocol closely, and of course that you check and make sure at all times that you're using the correct patient samples. Okay, so how do we know that the test has worked? So remember, this is why you are always asked in an exam to list something about AHG test reactions, whether it be false negative, false positive, or factors affecting. Okay. So to stop, to check that we have actually added our AHG reagent, that's why we add our AHG control cells. And we have a positive control in our screen, which is ORHD, positive cell sensitized with anti-D. So that allows us to make sure that if there was a positive there, that we would have detected it. There we go there. list causes of false negative, false positives. We always use, when we are using our panel, we actually use an auto control. When we are doing a screen, we include a positive control. So we include a positive control in our screen because the majority of screens that we do will be negative. So we need to be assured that if there's a positive reaction there, that we will detect it. With our panels, the only reason you do a panel is because you've got a positive result. You've detected an antibody in your screen. Therefore, you know some of the panel cells will be positive. Yeah? So we need to make sure that we've got something that we can compare those positive results to. And we use an auto control rather than a negative control, just in case it's an auto antibody. Because we do get auto antibodies, don't we? So when you think about our warm autoimmune hemolytic anemia and our cold hemagglutinin disease, we can have an auto antibody there, and we can pick that up when we use an auto control in our panel. So an auto control is where you use patient cells reacting mixed with patient's plasma. Okay, so you're checking to see if the patient has got any auto antibodies in its plasma, because they will then react with the antigens on the patient's cells. Okay, so in the IAT, the panel only, we use an auto control. In our DAT, we use a negative control, which is buffered normal saline plus patient cells. So what we're doing there is we're checking to make sure that if we have a positive DAT, that it's actually an antibody in the plasma that's causing that, rather than some sort of a weird plasma protein. Right. Okay, so I am cognizant of the time, so we'll just... Okay, so we've got positive control with our screening test to detect an antibody if it's there, and we've got our AHG control cells to check and make sure that any negative reactions are not false negative. This is how you set up an antibody screen on your worksheet. So you make sure that the patient's name is here, the unit record number or date of birth is there. You can then do your ABO and RHD grouping, and then you can put your AT1, AT2, AT3 are your 3 screening cells, and then your positive control. So with your first, also with every screen that you do, you put the lot number of the screening cells that you use and the date of expiry. So even though you've done your QC up here, I don't care. You still put your lot number here and your date of expiry here. The other thing that you do is you check the temperature of your water bath, because remember, that is one of the causes of false positive, of false results in your, or factors affecting your AHG. And you initial it so that we know who's done the test. Okay, so all of this is on your method manual on page 8. Then, of course, you add your results to your patient report. So I think we've removed these 2 parts of it now. So it's you will only do it by IA, indirect antiglobulin test. So that's the only test that you'll be using when you're doing your antibody screen. Okay, so patient name and unit record number or date of birth there, the ABO and RHD blood group there, and whether you the results of any antibody screens that you did there. Okay, and then if you need to identify the antibody, you put the identity there. Okay, so Melina will go through that with you in the prac today, and we will also you will understand how to use these patient report forms week after week after week, because you will be writing them up week after week after week. Okay, end of shoot, and you've got 5 minutes to get to the lab, but I'm sure Melina will not mind if you're a few minutes late. Any questions? Oh, brilliant. Excellent. Thank you for that, Nikki. So I don't know if everyone's reading the chat. Nikki's just said, as long as you've done your temperature screen and swipe your student ID on the door, so the ID swipe is right to the left of the doors of the building there. You should be able to let yourselves in. That's brilliant. So that means that people don't have to stand there and let other people in. Okay, so I'm stopping the recording.